fluid into the throat, causing soreness or a bitter taste in the mouth. Belching, a bloated feeling after eating. Dysphagia or difficulty swallowing. Water brash due to hypersalivation. Chest pain due to spasms of the esophagus. In fact, clients may think they are having a heart attack. And bleeding due to the breakdown of esophageal tissues. Complications of GERD include aspiration pneumonia, esophageal strictures, and perforation of the esophagus. If left untreated, GERD increases the risk of cancer of the esophagus. Diagnostic procedures include barium swallow, esophagoscopy with or without biopsy, and esophageal manometry. In addition, esophageal acidity, pH, is measured every hour for 24 hours. The nursing diagnosis for GERD is pain related to acid reflux. Treatment for GERD focuses on administering medications and educating the client about necessary lifestyle changes. Surgery is not the treatment of choice for GERD. Medications for GERD include antacids to neutralize acids and relieve heartburn, histamine receptor antagonists like Tagamet or Zantac to reduce the secretion of acids and relieve symptoms, proton pump inhibitors like pantoprazole, trade name Protonix, to reduce the secretion of acids, and gastrointestinal motility agents like Reglan to accelerate gastric emptying without stimulating the release of gastric acid. Because lifestyle changes are very important in managing GERD, advise the client to do the following. Eat small, frequent meals rather than large meals. Quit smoking. Avoid eating fatty foods and chocolate. Avoid drinking carbonated beverages, coffee, tea, and alcohol. Sit upright 30 to 60 minutes after eating. If the client is overweight or obese, explain how the extra weight exerts increased pressure on the lower esophageal sphincter, triggering GERD. Suggest weight loss programs. Also, have the client elevate the head of the bed 8 to 12 inches to prevent attacks of reflux at night. Advise the client to avoid wearing tight-fitting garments. Assure pregnant clients that their symptoms are likely to resolve after delivery. Pancreatitis is an acute or chronic inflammation of the pancreas. Acute pancreatitis is a life-threatening inflammatory process that is characterized by necrosis, hemorrhage, tissue death, and gangrene of the pancreas. Chronic pancreatitis is a progressive disease of the pancreas that is characterized by remissions and exacerbations due to the formation of scar tissue in the pancreas. The pancreas is both an endocrine and an exocrine gland that is located behind the duodenum and the spleen. The pancreas has hormonal and digestive functions. The endocrine tissues in the islets of Langerhans secrete insulin and glucagon, the hormones that regulate blood sugar. The exocrine tissue secretes digestive enzymes that break down carbohydrates, proteins, fats, and nucleic acids. Attacks of pancreatitis cause inflammation of pancreatic tissue due to the premature activation of pancreatic digestive enzymes. These enzymes cause autodigestion of the pancreas. Pancreatitis can also lead to insufficient insulin production, hyperglycemia, and diabetes mellitus. What are the major causes of acute pancreatitis? Gallstones, alcohol abuse, external blunt trauma, and drug toxicities to opiates, sulfonamides, steroids, thiazides, and oral contraceptives. The principal cause of chronic pancreatitis is alcohol abuse. Attacks of acute pancreatitis are precipitated by eating fatty meals and heavy drinking. Attacks are relieved by sitting up. Repeated attacks of acute pancreatitis might eventually result in chronic pancreatitis. As shown in this table, the signs and symptoms of acute and chronic pancreatitis are similar. Abdominal symptoms, with acute, severe, mid-upper abdominal pain that spreads to the back. Attacks last around 48 hours. With chronic, persistent, gnawing abdominal pain, in some cases, there is no pain. Nausea and vomiting. In both cases, they accompany abdominal pain. Fever, with acute, elevated temperature, with tachycardia. With chronic, low-grade fever. For acute and chronic pancreatitis, the following signs and symptoms are the same. Anorexia due to pain, weight loss, jaundice, dark amber or brown urine, steatorrhea, or foul-smelling stools, dehydration due to vomiting, and dyspnea from pleural effusion due to the spread of inflammation into the pleural space. The diagnostic tests for acute and chronic pancreatitis are also similar. Laboratory studies in both conditions usually reveal elevated serum and urine amylase, lipase, and liver enzymes. The blood glucose level, the bilirubin level, and the white blood cell count might also be elevated. Serum electrolytes, calcium, potassium, and magnesium are low. Diagnostic procedures include an upper gastrointestinal series, CT scan, and endoscopic examination. Important nursing diagnoses for clients who have pancreatitis are pain related to premature release of digestive enzymes, fear related to repeated attacks of pancreatitis, fluid volume deficit related to vomiting, altered nutrition, less than body requirements related to vomiting and anorexia, and impaired gas exchange related to pleural effusion. Currently, there is no cure for pancreatitis. Therefore, the goals of management are to reduce attacks, restore fluid and electrolyte balance, control the symptoms, and prevent complications, which include respiratory distress syndrome, hemorrhage, sepsis, bleeding abnormalities, and diabetes mellitus. During an acute attack of pancreatitis, the client should receive nothing by mouth. A nasogastric tube is inserted and attached to suction, and the client is given IV fluids. When the attack subsides, provide the client with a bland, low-fat, low-protein diet. With further improvement, the client may receive small portions of high-carbohydrate, high-protein foods. Instruct the client to avoid alcohol, caffeine, and spices. Refer clients who abuse alcohol